this is a little bit of anatomy and physiology, okay? Because I know it's been a while for some of you. Some of you may be skating at that 5-year mark on that A&P. But what I will tell you is that you have to sort of understand this. I won't test you on anatomy, but you have to understand the anatomy to be able to understand spinal cord injury. Basically, one of the things that you will see is think of the spinal cord as like an electrical cord. It carries current to something. It carries current away from the wall. So what you find is that the ascending pathways, meaning pathways that go up, are going to carry sensory information. Pathways that come down, descending pathways, are going to carry motor impulses. Okay? You will see that of those descending pathways, you have two major tracts. The pyramidal tract, the extrapyramidal tract. Think of your pyramidal tracts as corticospinal tracts. And one of the things that you can think about, if you look at the name of these tracts, you can figure out if it's motor or sensory. Cortico, okay? The cortex, spinal, so it starts in the cortex and ends in the spine, so it's a motor tract. If I were to say the spinothalamic tract, what type of tract would that be? Sensory, because spine to the thalamus, okay? Basically, what you're going to see is the majority of your motor impulses are going to be carried on that corticospinal tract. The ability to move arms, legs, mouth, whatever. Okay? Now, some of your extrapyramidals are going to be basically basal ganglia type tracts. Okay? Remember whenever we talked about extrapyramidal symptoms, okay, what did you usually see with those with your psych meds that cause those difficulties? Shuffling gait, tics, involuntary movements, okay? That's what the extrapyramidal tract typically does. It's involuntary movement, whereas pyramidal is voluntary. Now, with spinal cord injury, two things that you need to know. If someone says they're a C5 quad, depends on if you're talking to a neurosurgeon or neurologist, what that means. Or an orthopedic guy. Okay? One of the things that you'll see the neuro people use is they use spinal cord nerve or spinal level as their indication of where the injury is. Whereas your orthopods will use vertebral level. Okay? So it makes a little bit of a difference because you'll see just a minute that the spinal nerve exits slightly above the vertebral level. So it will make a little bit of difference of what function that person has. Okay? Now, what we typically see with spinal cord injury is that you get the immediate injury. And then what happens is that you get that circulation to that cord that's impaired by edema. And anytime you get that edema, you get ischemia. And again, you can have tissue necrosis. So you may have a primary injury because of an automobile accident or a fall or a gunshot wound. And then you may have a secondary injury because of that ischemia and edema that extends that injury. Okay? Often what you will find is that it will cause their level to be a little higher because of that secondary injury. It can also take a bruise to the spinal cord, and because of hemorrhage, make it a permanent lesion. Okay? All right. Gray matter, white matter, sensory motor pathways, we've talked about. Primary, secondary injury, we've talked about. Basically, what you're going to see is when you talk about the anterior portion of the cord, all right, you're talking about the side of the cord that's nearest to the stomach. When you're talking about the posterior or dorsal portion of the cord, that's the portion that's at the back. Okay? And there are all sorts of different tracts here. I don't want you to memorize these because Lord knows I don't have them memorized. Because what you're going to see is if I have damage to this area, I may have functioning other portions of that cord. Okay? So what you're going to see sometimes are what we call incomplete injuries. Now, with incomplete injuries, what we're going to see is different areas of sensory function. These dermatome charts are sensory only. It does not correlate with motor function. Okay? One of the things that I remember about the way this is that C4 is like a little cape around my shoulders. So I know if they have upper sensation here, then I know that's a C4 injury. Okay, they're intact up to C4. T4 is about nipple line. Okay, and we're talking about nice perky nipples. We're not talking about old lady nipples, okay? So what we're going to see is about nipple line. T10, belly button. Big toe is L5. And all of the genital area is the sacral area. Okay? Both sides. So what you need to worry about when you're caring for a patient with spinal cord injury is not only motor function, but sensory function as well. Because it will make a difference. And that's one of the things that confuses people a lot, is that I may have a patient with an incomplete injury that may not have motor function, but can feel. Okay? So just don't assume because this person is paraplegic or quadriplegic that they don't feel. A lot of times they may have patchy sensation, or they may be able to move without feeling because of that incomplete injury. Now, reflex arc is another thing you need to think about. What is a reflex? It's sort of automatic, okay? Basically, like when you're checking DTRs with your patients that you've got on magnesium because of preeclampsia, all right, you're checking your deep tendon reflexes to make sure that they're not decreasing because of the magnesium levels, okay? DTRs or reflexes basically loop through the spinal cord without brain function. So typically what you will find is that the sensory input comes in either the reflex hammer or whatever you use to elicit that reflex. It goes through the spinal cord and comes back out. It does not travel up to the brain. It occurs at that point. So what you often will see is that reflexes sometimes will be retained, but I'm going to give you that with a caveat after spinal shock has resolved. And we'll talk about spinal shock in just a minute. So think about reflexes as automatic at the level of the cord. Okay, so what are we talking about with impact on our healthcare system? Well, I've given you some statistics there. Approximately 12,000 new cases of spinal cord injury a year. Basically, from 73 to 79, the average age was 28 years, and most of those injuries occurred between the ages of 16 and 30. It's the old, hey y'all, watch this phenomenon, okay? But what we saw since 2005, the average age is 41. And a lot of that is due to our aging population. And so what we're starting to see is a larger number of people getting injured due to falls. Okay? What you see is that with motor vehicle crashes, okay, and that's the new terminology we'll talk about, motor vehicle crashes. Most of the time they're not accidents because they really could be avoided. 39% were due to motor vehicle crash, 28% were falls. Violence, 14.6%. Sports, 8.2%. And one of the things that we're seeing is that it used to be that only football would be causing spinal cord injuries, but we're seeing more and more from soccer. It's not without risk. Others are unknown, about 10%. Basically, what you're going to see is that the cost of care is pretty significant. I am not asking you these just as a background information. But look at this guy. Guys, a high quad, C1 to C4, $1 million that first year. And then about $100,000 every year thereafter. Okay? Cost of care is significant. The reason that these folks have such expensive care is that the majority of these people are ventilator dependent. Okay? We'll talk about that in a little bit. Paraplegics, about 500,000 that first year, 50 to 70,000 thereafter. Incomplete motor function at any level, you can see, is still very, very expensive. And these are direct costs. This does not account for loss of income or loss of productivity. Okay? $7.7 billion a year for direct medical care cost. Alright? It's extremely expensive. Alright, so let's talk about some of the causes. Hyperflexion, hyperextension, axial loading, and excessive rotation are pretty much what you're going to see that's going to cause this injury. Typically bullets, other foreign objects. I've seen spear guns, rebar, all sorts of things. Typically what you're going to see is cervical injury, C1 or C2, C4 to C6 are the largest number of injuries. And if you think about it, where are those vertebrae? They're right here. Just if you want to give an idea, that little bony prominence right there that you can feel, that's C7. So everything above that okay, is pretty much unprotected. The other thing that you will see is that the thoracic and lumbar injuries typically occur T11 to L2. Well, why don't I see injuries from T1 to T10 as often? I don't bend as much there, and what else? The ribs basically stabilize those areas. Okay, you do have some flexion, extension in those areas, but pretty much that column does not bend as well. Typically, if you see injury from T1 to T10, it's usually because of blunt trauma. Okay? All right, so let's talk about hyperflexion, hyperextension. Hyperflexion occurs when the head bends forward. Typically what you're going to see, this is a head-on collision, okay? Or a diving accident where the head comes in contact and bends forward over. I used to hate the first full warm day of spring because we would get 3 diving accidents from Jordan Lake. You can count on it. Usually about April 15th or whenever Easter was. Because people would dive into the lake not knowing that a tree trunk had moved into the place where they were comfortable diving last year. One of the things that you will see with hyperflexion injuries, okay, is that you will see dislocation often of the vertebral body, and then you will see damage to that cord. Okay? One of the things you need to realize is that you can have vertebral trauma without cord injury. You can have cord injury without vertebral trauma. Because often what happens is that the vertebral columns may stretch and then pop right back into place. But that stretch is enough to cause that cord to have problems with the fibers. Hyperflexion injuries, okay? Hyperextension injuries. The head will fall backward. Basically what you will see is something that hits the chin or hits the head, or a force from behind causes the head to whip back, causing again those fractures and or cord damage there. Okay? Now, rearing collisions, a lot of times what you will see is whiplash. Whiplash is not a spinal cord injury. It is a muscle injury. Okay? So hyperflexion, hyperextension are going to be one of the things that you're going to see most often as your causes of injury. Now, compression. Typically this is from falls from a distance and or diving accidents where the head doesn't pop forward, but there's a compression, a pushing on that head that causes some damage there. What you often see with these types of injuries is instead of a fracture of the vertebral column, they will fragment, okay, or what we call burst fractures. So what you see is a large amount of fragments with those compression injuries, and what you find is that those fragments may either push on the cord or actually pierce the cord itself. See a lot of these from people falling off of ladders, not necessarily falling on their butt, but we see a lot of them from people jumping from high distances, because unless they absorb some of the shock with their knees and they go straight leg, typically what you will see is the compression of that vertebral column. Okay? Axial loading. Basically what you're going to see is something causes the head to whip around. And this is more than you're just flipping your hair. Okay? Basically, whenever there's a force like a boxing hit that causes that head to whip around, we see a lot of this in people that are unrestrained in car accidents as well. Okay? So, hyperflexion, hyperextension, compression, and axial loading are the mechanisms that you see. Now, trauma. This is a bullet. And this is a knife. Pretty good size one, too, I would say. This is probably a butcher knife. Okay. No, I don't think that one's a shank because you can see it's too, okay. Complete lesions and incomplete lesions. Think of a complete lesion as this. I've got my nice little spinal cord. That's my brain. Okay? With a complete lesion, something has happened that it severs. So that there is no connection between the lower portion of the spinal cord and the brain. Complete lesions usually means that there is something that has caused damage all the way across the gray and white matter. And so typically what you see is a complete loss of function below the level of the injury. Okay, so incomplete lesions. What you typically see is this. Well, I've got some function that's damaged here. Okay? So that what's going to happen is that I'm going to have varying levels of function. All right, you remember when we talked about head injury, the right side of the brain controlled the left side of the body and vice versa? Okay? What you're going to see with spinal cord injury is that that's a match with a flame, I'm sorry. That's a foot. What's going to happen, or an arm or whatever. Okay, so if I have a burn here, that information is going to go into the spinal cord, either crosses at that level and goes up, or crosses at one or two levels above and goes up. So whenever you have sensory information, it crosses at the level that it enters or slightly above. So it's sort of the opposite, okay? Right brain, left motor function, okay? So left sensory crossing in the spinal cord and going up to the left brain. Okay? I'm sorry, let me do that again. Left sensory crossing at the spinal cord going up that way to the right side of the brain. So when you're talking about injury to that cord that's complete, I'm not going to have motor function or sensory function. Okay? Below the level of the injury on both sides. when I'm talking about sensory function for an incomplete, I may have varying levels of motor function, varying levels of sensory function on that opposite side. So, have I confused you enough?
Yeah.
Okay. Just remember, this stuff gets very confusing, and I'm about to confuse you anymore. Hopefully, it will be a little clearer when you see what these are. Okay? Central cord, anterior cord, or Brown-Séquard. With central cord syndrome, let's skip that for a second. Central cord, basically what you've got is a lesion in the middle of that cord, okay? So it basically covers a lot of the gray matter, but it also covers some of your white matter. All right? Typically what you're going to see with central cord syndrome is it's caused a lot of times by hypertension. Where there's a bleed. Now, a lot of times what you will see is that it can also be caused by hyperextension injuries. What you see with central cord syndrome is a spastic paralysis of the upper extremities. The arms are not functional. What you're going to see is incomplete loss of the lower extremities. So I may be able to feel, I may be able to move or walk with my legs, but I can't use my arms. What you're going to see is varying effects on bowel, bladder, and sexual function. Okay? So these people may be able to urinate because they do feel the urge to urinate or to have a bowel movement, but they can't use their arms to wipe or hold or whatever they need to do. Give you an example. We used to get a lot of people that got drunk and FOP, fell off porch. It is not an approved abbreviation. Okay? We had this gentleman come in that had central cord syndrome because he did get drunk, fell off the porch. He was unable to use his arms, but he had some movement of his legs. Okay? He basically eventually was able to have intact bowel and bladder function. Initially, we did have to catheterize him and do a bowel program, etc., etc. Well, he probably stayed in the hospital a lot longer than he needed to because there was no place for this gentleman to go. Well, what happens a lot of times you'll find with your patients with spinal cord injury is that if they can be rehabbed, where they can take care of themselves or their family takes care of themselves, they go to rehab. If they cannot be rehabbed, a lot of times what you will find is that these people will go to nursing extended care facilities, long-term care facilities. This man had no family because he was estranged from the family. No nursing home in their right mind would take this gentleman because he had done 20 years in central prison for hacking his girlfriend to death with an axe. So, nursing homes don't take convicted felons. Even if they can't use their arms. Eventually, we did get his sister to come to take him home, but she made the doctor's promise he would never regain the function of his arm. And either he didn't, Or either he did and we just didn't hear about it.
So they can regain function?
Usually not. Usually not, because what you find is that if this is due to a hypertensive bleed, basically what happens is that tissue necroses and liquefies, and it's a permanent lesion. Okay? So think about central cord syndrome. You may be able to move your lowers, maybe having intact sensory, but the upper arms typically don't move. Okay? This is basically what you're going to see is an injury, cervical or high thoracic. Okay? Central cord. Anterior cord syndrome. Again, paralysis below the level of injury. You're going to have loss of temperature and pain sensation below the level of injury. But below the level of the injury, you're going to be able to feel position, vibration, and touch. And this is what freaks a lot of people out. Well, you're paralyzed, and I can pinch you, but you don't feel that pain, but you're telling me that that sock is twisted on your foot? How can you feel that? Well, they can. Okay? Because what you see is position, vibration, and touch. They're able to feel. Light touch, deep touch, they're able to feel, but not a painful sensation. Okay? It's weird. Okay? One of the things that you just need to realize with these cord syndromes, I'm going over you, if you see them on NCLEX, if you see central cord, anterior cord, or Brown-Séquard, just think, oh, yeah, that's one of those funny ones. And they might try to trick me on this one. Okay? Basically, just realize that just because they're paralyzed, that they still may be able to feel. With your anterior cord people, okay, usually that's because of blunt trauma to the abdomen that goes basically to the cord. Now, this is the one that gets real sticky. You're not there yet, but you will be. Okay. This is the one that you're going to see. This is because what we call a transverse hemisection. Think of this as the one that occurs because of a bullet wound, knife wound, or some type of impalement, where the spinal cord is cut partially through. Doesn't go all the way through. Just halfway through. It's like when you're slicing cake and you only get the top 2 layers. Okay? You don't go all the way to the plate. What you see is paralysis below the level of injury on the same side of the body. You see contralateral, which means what, guys? Opposite. Loss of pain and temperature below the level of the injury. But you see ipsilateral, loss of proprioception below the level of the injury. So I've got one side that can't move, one side that can't feel, one side that can't tell where my leg is. So, the side of the body that can move doesn't know where it is. Typically, to rehab these folks is that, usually you tell people with the walker, don't look down, look up to see where you're going. These people actually will have to look down to see if their foot is up or down. They're very, very difficult to rehab. Something caused half of the cord to be damaged. Like I said, most of the time it's penetrating trauma. Knife wound, bullet wound, spear gun, whatever. All right, this is just another example. This is basically showing you that some of those pathways cross at the same side. Some of them go up above a level, and that's why you get loss of pain and temperature on one side and loss of proprioception and vibration on the other. If you see Brown-Séquard, think, oh God. This one is going to be difficult to answer. Okay. All right. So, remember I told you there's a difference between vertebral bodies and nerves? Remember these how many cervical vertebrae do we have? We have 7 vertebrae. We have 8 cervical nerves. Okay? That's the difference. That's why whenever someone talks about a spinal cord injury, are you coming from vertebral injury or are you talking about cervical nerve injury? Okay. 7 cervical vertebrae. So basically what I'm telling you is that if I have a C7 vertebral fracture, more than likely what will happen is that my cord injury will be at C6. So it's slightly above. 12 thoracic, 5 lumbar, 5 sacral. Remember the sacrum as a vertebral body are fused, but there's still 5 sacral nerves. Okay? Where does the spinal cord end in the vertebral column? That's lumbar. L1, L2. Okay? Remember, that's why they do the lumbar punctures at about L3, 4. Because what they're doing is that they are going below the end of the spinal cord. But remember, those nerves sort of form, you remember the cauda equina, that horse's tail? Okay? So, typically what you will see with lumbar or sacral damage, it's often way up here at L2 that has the problem. But you will have lower lumbar or sacral damage because of the nerve compressions. Okay? So, thing I want you to remember. Of these cervical vertebrae or cervical nerves, I am very, very, very concerned if someone tells me they have a C1 through C4 cord injury. Why? Breathing, respiratory function. All right? Basically, what you're going to see is you do not get diaphragmatic function or innervation until you start with C5. You really don't get intercostal muscle movement until you have an injury below T1. So I came up with a poem so that I could remember some of this stuff. So C1, C2, they're turning blue. At C2, they will not breathe. C3, they will not breathe. C4, they may be out the door, possibly the back way. At C5, I can keep them alive. So C1 through 4, those patients will be ventilator dependent or diaphragmatic stimulator dependent. At C5, you start having some diaphragmatic innervation, and they will breathe spontaneously, but they don't have good intercostal movement. So what you will see is decreased respiratory function. Anytime you have someone with cervical cord injury. C1, C2, I'm turning blue. At C3, they will not breathe. At C4, they may be out the door. At C5, I can keep them alive. Okay? Now, the thoracic vertebra controls basically the upper body. What I really worry about is those intercostals. The intercostals are about T1 to T6. Lower than that, GI function. Lumbar and sacral, bowel, bladder, sexual function are what's going to be concerning. T1 to T6 are intercostals, the chest wall. Questions on that? At T6 to T12 is GI function. Like actual peristalsis. Okay. All right, let's take a break before we talk about. All right. Now, I know Ms. Rummel has talked to you about hypovolemic shock and septic shock and cardiogenic shock. This is neurogenic shock, okay? It's called spinal shock or neurogenic shock. Basically, what you need to remember about this is that you have a temporary loss of reflex function below the level of the injury. You have flaccid paralysis below the level of the injury. You have loss of the spinal reflexes, loss of sensation, absence of visceral somatic sensation. In other words, I can't tell if my belly hurts or if I got to pee or got to poop, okay? I can't, even if I could tell, I couldn't do it because I have bowel and bladder dysfunction. This one, the loss of the ability to perspire sort of stays. These all will eventually maybe get better or maybe completely resolve. But your patients with spinal cord injury lose the ability to perspire below the level of the injury. Why is that concerning? That's the way that people regulate their body temperature. So your patients that have high cord injury are basically going to be like lizards. Their body temperature is going to be controlled by what the room temperature is. Okay, so if they're in a cool environment, their body temperature is going to be cold or cooler. If they're in a hot room, their body temperature is going to be similar to that temperature. And remember, one of the ways we thermoregulate is perspiring to get off excess heat. Well, if I'm a C4 spinal cord injury, pretty much I can't sweat except on the top of my shoulders and on my head. So I lose that ability to perspire below the level of the injury. And that stays. Now, what you see because of those problems is neurogenic shock. You get a systemic hypotension. Okay? And we're not talking significant. 100 to 110 over 60 to 70. It's a milder version of hypotension. Warm skin, bradycardia, and a lower body temperature. Okay? The way we treat this is with IV fluid or plasma expanders like dextran, something that will pull in fluid. Now, think about, why am I getting this hypotension with these patients that have lost motor function below the level of their injury? Go ahead.
There's nothing to move the blood back.
There's nothing to move the blood back to the heart. Basically, what happens with these people is they vasodilate. So the blood stays in the periphery. That's why it's mild. Now, if you have someone with a spinal cord injury that has that systemic hypotension and they have that bradycardia, you treat it with IV fluid. Now, what if I have a person with a spinal cord injury that has an 80 over 40 with a pulse rate of 130? What am I going to be looking for? Blood loss. Typically, you not only see patients with spinal cord injury, but you may see other traumatic injuries. I'm going to be making sure that I've done a belly assessment to make sure that they don't have some type of blunt trauma to the abdomen. This is the difference between neurogenic shock and hypovolemic shock. Mild systemic hypotension and bradycardia versus hypovolemic, which may be a lower hypotension and an elevated heart rate. Okay? Neurogenic shock, you treat with IV fluid or plasma expanders. Typically, they do okay. One of the things that you will see with hypotension from hypovolemic shock is you see more respiratory compromise because of not having the oxygen to carry the blood. With neurogenic shock, it's not a problem with blood to carry the oxygen, it's the actual movement of the lungs. You breathe for them, typically their oxygen levels come right back up. Okay? Hypovolemic shock, you're going to have someone hypotensive, tachycardic, with low O2 sats and low PO2s. Okay? Very big difference. Now, how do I tell when neurogenic shock or spinal shock stops? Typically what you will see is that neurogenic shock starts about an hour after the injury, and most of the time you'll see it last for a week, but it can last up to 6 weeks. One of the ways that I can tell if spinal shock is resolving is I get return of reflexes. So as part of my nursing care every day, I'm going to be checking for those reflexes. These are the three that are very easy to see. They're cutaneous reflexes, meaning that they can do with the skin. Okay? The anal cutaneous reflex. Basically, if you take a gloved finger and stroke the outside of the rectum, it will wink at you. It's called the anal wink. Okay, so for years after I've done this lecture, people go at me. Anal wink. The other thing is that if you were to place your finger in the rectum and do that, you will feel the contraction. That is a reflex. Why is that important to me as a nurse, other than I know my spinal shock is gone? Continence. If you have not got the ability to contract that anal sphincter, then you're going to be incontinent of bowel. Okay? All right, bulbocavernous reflex and cremasteric reflexes can only be done on guys. Why? Well, what do guys have that we don't? I've seen some women with some. It's the other part. Bulbocavernous reflex. Basically what you do, again, gloved hands. Take your hand, place it under the scrotum, squeeze the end of the penis. What will happen is that the testicles will elevate. Okay? You don't, just a gentle squeeze is enough. Okay? So why do I run around squeezing wee-wees? Basically, that may mean that they're going to have return of bladder function. Okay? Because it is a reflex. Again, squeeze the glands of the penis and the testicles will elevate. The muscle underneath the scrotum will contract. Now, cremasteric reflex. You can't test it on yourself, guys, so don't even try. Someone else has to do it. But basically, if you stroke the inner aspect of the thigh, the testicle on that side will elevate. Again, it's a reflex. So those are the three reflexes that I'm testing to see when spinal shock resolves. When I see those return of that reflexes, that means that I'm going to see sort of what kind of function that these people are going to get back. Okay? Now, what happens is after spinal shock, a problem may occur whenever you have muscle movement. You may have spasticity. And I have seen some of these patients have such severe spasticity that you have to have elevated side rails because they'll spasm off the bed. Typically we treat those with antispasmodics, but spasms can be a problem for these patients and they can be extremely painful, especially for those that have varying levels of sensation. Okay? The other thing that you may see after spinal shock is you may see some return of bowel and bladder function in your high thoracic or cervical injured patients. Typically what you will see is that if you have patients with lumbar or sacral injury, bowel, bladder, sexual function is gone, because it's too close to the areas where it is governed. But with some of your high cervicals, they will have what we call sacral sparing, meaning that they're able to be continent of bowel and bladder. And you get them on a program where they have either triggered voiding, okay? Triggered voiding is sort of like whenever you used to do sleepovers and you put the hand in the warm water and people pee, okay? Typically what you will see with triggered voiding is that if you scratch right above the butt crack, it will trigger people to void. And a lot of times we teach them how to do that and they can void. Basically with after spinal cord shock has resolved, that's the best time to start these people on a bowel program so that they can be continent of stool. The spasticity usually stays. And a lot of times what I've seen a lot of paras use that spasticity to help themselves get out of bed. They could control it just a little bit. And it will help with movement of their legs. But it can be extremely painful. All right, with collaborative movement, basically one of the things that I'm going to tell you guys, emergency care, your EMS folks, are going to be your experts at making sure that someone is assessed and stabilized at the scene of the accident. One of the things that you don't want to do if you come on an accident, don't allow that person to get out of the car until they've been checked out and their neck immobilized. Okay? The only reason that you would want to move that person is if the car was on fire. Because the chance of either complicating that potential cord injury is very, very great. You want to stabilize them before you move. Typically what you're going to see is they're going to use a collar for cervical injuries, and they will use a backboard. Most people that are extracted from cars are placed on a backboard, and the reason that you keep them on that backboard is to make sure that they don't have thoracic or lumbar injuries. Okay? They can't stay on that backboard. The collar is kept in place until cervical injury is ruled out. One of the things that you're going to see is that with head injury, always assume that this person has a concomitant spinal cord injury until it's proven otherwise. With any motor vehicle crash over the speed of 30 miles per hour, assume that they have spinal cord injury until proven otherwise. Remember, we talked about C1, C2, I'm turning blue, okay? Remember, C1 to C4, they will not have spontaneous respirations. C1, C2, C1, basically, remember, sits at the base of the skull. C2 is a vertebra that has a little, what we call the odontoid process. It looks like a little thumb. It sort of sits up here. What you see with C1, C2s is that they can have what we call a hangman's fracture. And what happens is that odontoid process is broken off and driven into the spinal cord. People that were hung back in the old days, still up until 1950 in Nevada, basically what they did is made sure that the noose was like this so that that odontoid went into the cord instead of strangling them to death. So when you hear a hangman's fracture, it's that little odontoid process. This is the fracture that Christopher Reeve had. Okay? Superman. So basically what he had was a C1-2 fracture. And that's why he was ventilator dependent the rest of his life. Now, what we also would want to do is, if we hear about a hangman's fracture, is to make sure that that collar stays on. Because you don't want that little odontoid process moving around. Basically, at the scene, what they're going to do, stabilize and treat any respiratory insufficiency that they've got. Okay? Remembering, if you are suspecting spinal cord injury, how are we going to open the airway? Do you do head tilt, chin lift? Jaw thrust. Okay? And I'm going to tell you, it's difficult as I'll get out to intubate someone using jaw thrust. Now, collars. These foam things are great for whiplash and lawsuits. But they have no place in treatment of spinal cord injury. You're talking about a Philadelphia collar, which looks sort of like this, or a Miami J. Most of the EMSs have gone to the Miami J now. I'll just pass this around and let you see. But what you will, let me do this first. What happens is that they would put this on the back, like this, so that the back of my head and my shoulders are supported there. Then they slip this on like this. And then the Velcro straps go on. Okay, if I can do this, if I can move my head, nod, I'm going to yell at you. All right, because I want no nodding. I want no head movement. Basically, to do nursing care, where's my strap? There it is. To do nursing care. Basically, if I am taking this collar off to look to make sure that there's no skin damage, this person will be flat. I unstrap one side, unstrap the other. I've got some person holding their head, and I remove the collar to see, making sure that the other part stays on. Okay? And then I would put the collar back on, do a log roll with the straps on, and then take the back off to do my assessment. Okay? So you always, always, always leave that collar on with some assistance to hold the head if you're doing assessment until that spinal cord injury has been ruled out. At that point, they take the collar off and you wash their neck like crazy. Because if you think about it, feel that plastic on your skin. It gets very hot. It gets very sweaty. And typically what we have to do is just replace the collar. Now, Miami J's are great. And they're hard plastic. And the nice things about them is they have a hole here in the front. So if I've got a patient that has a tracheostomy, there's a place for that trach to come out. Okay? Whereas this one does not. This is a more stable collar than the Philadelphia. But this one is much cheaper. I want to say this one's about $180. No, not that one, the Miami J. Okay? Now, that's EMS. What you're going to see whenever you come in with a spinal cord injury is that we want time, location, type of event. Was it motor vehicle accident, a fall, a gunshot wound, which if it is, you've got a whole nother set of problems. Any pain that they may be feeling or the lack thereof. With physical exam, we're going to do our ABCs. Airway, breathing, circulation. Remembering with those high cervical injuries, C1 through 4, I'm not breathing, so someone's got to breathe for me. C5, C6, C7, I'm breathing but not well because I don't have intercostal muscles to move. So I'm going to probably have some acid-base abnormalities. So what do you think that acid-base balance abnormality would be if I've got someone that's hypoventilating? Respiratory alkalosis, acidosis, because you're not blowing off the CO2. Okay, remember alkalosis is okay. Acidosis, you're retaining CO2 because you're not breathing deeply. And that's one of the things you'll see with these patients is their respiratory assessment. You probably are going to hear upper lobes, but your lower lobes are going to be very, very, very decreased, if at all, any sounds. Okay? Circulation, remember, with that spinal shock, you may see that hypotension and bradycardia. Typically, other than with spinal shock, you may not see any problems with circulation. But I'm going to tell you, if you see others, think about other injuries. Okay? Because sometimes you will see patients that have multiple injuries along with their spinal cord injury. Now, one of the things that I'm going to be doing as part of my nursing assessment is I'm going to be doing what we call a sensory assessment. And I'm going to have a chart very similar to one of these, and I'm going to mark where this patient's able to feel. One of the things that you always remember when you're doing sensory assessments, I don't care if it's on a spinal cord injured patient or any patient. Do you have it online, front and back? Because it does. It says front. Okay. What you're going to see is that all sensory assessments are done with patients' eyes closed. You get a much better, reliable assessment than if you have them open. Okay, if you've got someone that has their eyes open, all right, tell me where I'm touching you. Well, they look down and say, well, I'm on my big toe. The other thing that you're going to do, guys, is that you're going to start low and come up. All right, you go from where they can't feel to where they can feel. You get a much more reliable assessment. Because if I start up here, all right, tell me when you can't feel. And you know that their level is here. Sometimes it's not as reliable. But definitely what you're going to find is if you start here and come up, they're going to say, oh yeah, I feel that. A little easier. And it's more reliable. So eyes closed, start where they can't feel and come up. Just as an example, with dermatomes. With sensory, like I said, T4 is about nipple, T10, belly button, L5, like this little piggy went to market, okay, this is what I'm talking about here, is L5. S1 is the wee toe, the little toe, okay? So if I know that I have got someone that can feel this toe, I'm going to be sort of happy because this person may eventually be continent of bladder and bowel. Okay? Diagnostically, one of the things they're going to do is a C-spine series. Typically what you'll find is those are AP and lateral, meaning front to back, side to side. The other thing, when they do a series with these patients, they do what they call a swimmer's view, meaning that they bring their hands out like this, like you're diving, okay? Because what that gives you is a very good picture of C7. The other thing is they will do an open mouth view, And that allows them to see C1, C2 without the teeth in the way. So in addition to AP and lateral, those are the two that make the C-spine series. Now, if you ever work in the ED, or if you ever have to accompany a patient to the X-ray for C-spine series and they've got a collar on, these have to be done without the collar, especially if it's one of the Miami J's. So what you're going to be responsible for is to make sure that that patient does not move their head, okay? Or that someone in X-ray doesn't go jerk, because you can extend their cord injury. CT, MRI are done. Fluoroscopy may be done. SSEP is somatosensory evoked potentials. Somatosensory evoked potentials are a test that looks at nerve conduction, both to the brain, to the cord level, and from the cord to the brain. It will tell you how much damage is done to those nerve pathways. Somatosensory evoked potentials look at nerve conduction, either from periphery to the brain or brain to the periphery. So it looks to see what kind of damage that there is. Why do we do ABGs? Breathing. Okay? So you're going to see fairly frequent ABGs on your patients with C1 to C4 fractures. Now, one of the things I want you to do when you get home is in your book, it talks about high-dose steroid protocol. Take your pencil or pen and mark through that. They no longer do that. Okay? Basically, about 10 years ago, they tried this trial of very high-dose steroids to see if they could have decrease in the amount of edema and would try to help to decrease the amount of spinal cord injury that these patients had. Basically, results showed that it didn't do that much. However, what happens if you give someone high-dose steroids? All sorts of diabetes and wound healing and all sorts of problems. So that is no longer recommended. So just mark through your book on that. Okay? Now, the other thing that they're trying right now is M1 gangliosides and stem cells. So who knows what that will do in the future. But we are no longer doing high-dose steroids. Typically what you will find is they only do surgery on these patients if there is cord compression or there are bone fragments in that spinal canal. Most of the time they're just stabilized with immobilization devices. And the one that they do most often is a halo and jacket, okay, or halo and traction. All right. Get rid of this pillow. Basically, your pins should never touch the bed. What I would want is this pillow more under her shoulders so that her head is sort of hanging freely. Okay? With a halo, it's exactly what it sounds like. It's a metal rim that goes around the head. It is held in place by skull pins. They're pointed at the end and they're screwed into the skull. Any of you know what a torque screwdriver is? Okay? Look it up if you don't know. But basically, it's a screwdriver that has a pressure gauge on it, so that when you turn, it will tell you how much pressure you're exerting. Okay? And that's what they use to tighten these pins. Typically what you will see is that when one of these devices is put into place, the skull pins are placed. What they do is with a scalpel make a little hole so that it doesn't twist skin in there. And then they insert the pin and tighten. Okay? And just like with the lug nuts on your car, you don't tighten this way, all the way around. Tighten this one, tighten this one, tighten this one, opposites, so that you don't get a wonky head. Okay. It depends on your patient. Okay. I could be crass and say with men that they have thicker skulls, but they do. So you may see a higher torque for an adult than you would a child. One of the things I will tell you is that we cared for a 16-year-old guy, African-American guy that fell off a trampoline. That's why my daughter never gets on them. At least that mom knows about. Let's just put it that way. Had sickle cell disease. And one of the things that we did not know, but we found out, is that sickle cell tends to weaken the bones. So he was torqued up to tighten his screws. It perfed. He developed meningitis and died. So think about sickle cell weakens your bones. That's just an FYI. Typically what you will see is 5 to 10 of torque, okay, on those. Typically they put them in day one. They tighten for 3 days in a row, and then every third day they tighten. So these people will be in this halo to decompress and align those vertebrae for maybe 24, 48 hours, and then they're typically put in this jacket very quickly because this is more stable and there's less chance of movement for the neck. Now, think about nursing care for this, guys. What are you going to worry about? Skin breakdown. Yeah. You can see she's got on a t-shirt. That is probably for modesty in this picture. But typically what we try to do is we get them to do, like, whenever they go home, Velcro t-shirts so that they can put a t-shirt underneath. This is sheepskin lining, okay, which means it's hot, it's sweaty, and what we do not want you to do, or them to do, is to put baby powder under it. Because what happens is if you put baby powder on this sheepskin, it gets little knots, okay? That's okay for someone that's intact, but someone that has no sensation, they can have serious skin breakdown in a very, very short period of time. Okay? Now, with halo and traction, these are the safety issues. Never, ever, ever pull on any portion of that halo device. I mean, it looks like a great handle you could just pick up and haul them up out of bed with, but don't do that. Because what you're going to do is it may change the torque on those pins, and it actually can rip the skin if it's pulled hard enough. Pins should always be up off the bed. You don't want that pin digging into the bed, because what that's doing is decreasing the amount of support that neck has. So whenever these people are in the bed, there's always a pillow behind their shoulders to elevate that halo off the bed. Yeah, they're sort of dangling in the breeze, but that's what you want. Okay? And if the patient looks at you and says, "Are you doing okay?" and they go, that's a no-no. Mm-hmm. It needs to stop that right now and let me call the doctor to get you tightened. Okay? The tightening or the adjustment is done by usually your orthopedic guy. All right. Now, look at this right here. It's a hard plastic with this. Several years ago, I was asked to get a patient back in the bed out from a wheelchair. And so I did a stand pivot and pivoted him in the bed, and he peed all over my leg. And I was about to go off on this guy. And then I looked at him and I said, oh crap, you're not breathing. Oh crap, you don't have a pulse. Basically, he had thrown a pulmonary embolus and had died right there whenever I pivoted him over. Well, back in the day, to do CPR, you had to take this sucker off. So here I am with my hex wrench just as quickly as I can getting this part off to do CPR. Now what they've done is these things have what they call a living hinge. There is a little line right here that if you have to do CPR on someone, you flip off the Velcros, flip that hinge up, and you can do CPR. Okay? So, much easier, better for the patient. But once that hinge has been flipped up, if the patient survives, then they have to change out the front plate. Okay? But that's one of the safety things. Typically what you're going to see is that there is a wrench that is usually a little hex wrench that's taped to the front of the jacket so that you can tighten, the doc can tighten these locations. The pin has to be done by torque wrench. They don't leave those hanging around because they're so expensive. Uh-huh.
If they've had pervasive trauma, is there any chance that ever causes compartment syndrome if they're internal?
Typically, these don't cause compartment syndrome because they're not that tight. Now, where they could be that tight is if you crank that Velcro. But typically what you will find is that you can't get it that, but there's no compression there. Okay? All right, back to, if patients are able to ambulate, they'll be top heavy. Balance is affected. This halo and jacket weighs about 20-25 pounds. So a lot of times what you will see is that patients sort of lean forward. They either walk with a forward lean or they walk with a walker. Balance is something that you got to worry about. Did I tell you the story about my 101-year-old lady? Got a call from the ER. Renee, I've got a cervical fracture for you. Okay, how old? 101. And I'm thinking, oh my God, this woman is never going to get out of the ICU, and if she gets out of the ICU, she never will go home, da-da-da-da-da. Okay, so I'm doing her admission assessment. I said, Miss So-and-so, how'd you break your neck? She said, well, the GD birds were in my cherry tree, so I was trying to put the net on it, and I slipped and fell. 101-year-old in the top of her cherry tree fell out. So I thought, well, we'll put a halo on her, but she won't have any problems. She will have problems. Put the halo and jacket on her. PT got her up. She hopped out of the bed and was walking around. She was ready to go home in 3 days. What happened, though, is that the night that she was admitted, I was getting ready to go home, and this woman walks up with a walker. Okay, it takes her probably 20 minutes to go 15 feet. She gets to the desk and says, I'm here to see my mother. 83 years old. The 101-year-old lady was taking care of her daughter. So we had to get home health, but for the daughter, not the mom. So, they'll fool you. The other time is that I'm driving down, not Providence Road, because it was in Durham, Irwin Road, which is very similar to Providence. And I see one of my patients in a halo and jacket jogging. Not to mention, it's 25 pounds. Irwin Road is very similar to like Highway 73, okay? It's very busy. The thing about these halos and jackets is you have this vision, okay? If you have peripheral vision, you have to turn your head, like your whole body, because your head no longer moves. Well, not to mention the jarring on the pins, but he was really at risk for being hit by a car because of not being able to see. Of course, I pulled over and I said, Mr. So-and-so, get in the car. I'm taking you home. You cannot be jogging down this road. Well, I didn't think so, but I was getting tired of being in the house. Like, well, let's go to the mall instead. But yeah, they do very well if they are intact. Now, what you will find is they will do halos and jackets for both intact people, meaning they have a vertebral damage, but no spinal cord injury, because what they want that is to heal. What they also do is they will do the halo and jacket for people with spinal cord injury with vertebral fracture to keep from extending the cord injury. Okay? Now, pin care. Because it is a pin that goes into the bone, we have to assess for swelling, redness, or drainage at that pin site. Basically, frequency of your pin care is going to be determined how long that pin's been in place. We do very frequent pin care when they're first placed, but say, for example, they're discharged from the hospital, they go home, typically we tell them to do pin care 3 times a day. Like morning when they get up, sort of mid-afternoon, and then right before bed. What they want, what materials they want for pin care will be a doctor's preference. Majority of time it's half-strength hydrogen peroxide and normal saline rinse. The majority of your docs do not like Neosporin or any of those ointments, because remember, this is a metal piece that's in their head. We don't want any rust. Okay? Basically, you may see just cleaning up with hydrogen peroxide and saline rinse. Typically what you will find is that if there is a pin site infection, they will take that pin out and move it. Allow that pin site to heal, but they don't want to compromise the stability of the neck. They don't take the whole halo off, they move the pin site. And yes, these people do have some scars, typically forehead and the back of the head from these pin sites. Most of the time what you will find is that with these halos and jackets, they'll be issued 2 sets of the sheepskins, one to wear, one to wash, because you can wash it and don't put it in the commercial dryer. It has to be air dried. But you want to change it out. Now, nursing care with these patients is meticulous skin care. We lay them flat in the bed with that pillow behind their shoulders to elevate the head. With bath, you're going to inspect your skin front, turn them, and then inspect on the back. Okay? If you notice any breakdown, it needs to be dealt with immediately.
Did you say elevate the bed?
No. If I am anytime I am undoing, yeah, anytime I'm undoing those Velcro straps, that patient needs to be flat. But the pins need to be off the bed. Okay. Questions about halo and pin care? Okay. These are our early nursing diagnoses. These are the ones we're going to worry about later. So let's go through some of them. We'll do breathing patterns and then we'll take another break. Ineffective breathing pattern. Remember, these are my people that have C1 through C4. Injury really to about T6, because you're going to have someone that has either no respiratory drive, or you're going to have people with a respiratory drive but very poor muscle control or no muscle control to move that chest wall. Rate, rhythm, and depth. As I said, the depth is probably going to be just upper lobes on a lot of your patients until you get to about T6 or below. Oxygen sat, ABGs are monitored. Supplemental oxygen is prescribed. Most of the time you don't see these people on oxygen. But again, on that ABG, you may see a respiratory acidosis. Eventually, it will compensate. Turn, cough, deep breathe every 2 hours on the dot or more frequently. With your cord injured patients, you're going to increase their PO fluids to about 3,000 a day. Number one, that's going to keep my secretions liquid. Number two, it's going to help me with my bladder to prevent UTIs. And number three, because these people are immobile, calcium leaches out of their system. And they're at risk for kidney stones. So that extra fluid will help flush that calcium out of the system. Ineffective gas exchange. Vital capacity and respiratory effectiveness are basically monitored. Now, one of the things you have to worry about with cord injury is, especially in that acute period, I'm doing frequent checks of sensory and motor function because swelling can change that C5 spinal cord injury into a C4 injury. Okay? So that I want to make sure I'm doing very frequent checks to make sure that my respiratory function remains stable and intervene if necessary. Now, what you will see is this is what we call a quad cough. Okay? It's sort of a modified abdominal thrust. One of the ways that we cough and get an effective deep cough is contract our intercostal muscles to elevate the diaphragm to forcefully cough. Your patients with quadriplegia cannot do that. They have no innervation of their intercostal muscles. So what you would do is place your hands on either side of the abdomen underneath the rib cage, and as they cough, you're going to push up, sort of like you would do with those abdominal thrusts with someone with an obstruction. And what you do is elevate the diaphragm. Please don't perforate the diaphragm, but you help them with those intercostal muscles by moving it up. And it will deepen their cough. Okay? Typically, this is what we're going to do with these patients every 2 hours. When they cough, You do that assist, it's more of a, okay? So what you're going to do is help them cough with that. Neurogenic shock, we talked about. Occurs within 24 hours after injury with patients above T6. Adequate hydration. How do I tell when neurogenic shock is resolving? Return of those reflexes. Okay? Alright. So, let's take a break and be back at 5 after. Impaired physical mobility. One of the things that we want to do is to make sure that as soon as this person is stable, we want to start rehab on this patient. Performing passive range of motion, okay, is going to be one of those things that you're going to do. If the person has some muscle strength or muscle ability, then they're going to do active range of motion as well. One of the things that you will find is that maintaining that muscle strength and mobility is extremely important in order to be able to have them to become as functional as possible. One of the things that I see with a lot of my patients is that if I have a C4 injury, pretty much all they're going to be able to do is turn their head. Okay? C5s, I'm going to start seeing that they've got some bicep movement. So they're going to be able to do this. Okay? Move their hands up. If I have C6, they have some extensors. So someone with a C6 injury may be able to feed themselves with some assistive devices. People with C7 injury basically are going to be able to flex, extend the wrist. And people with C8 are actually going to be able to be functional to do some finger extensors and flexors. So if I have someone with a spinal cord injury in the cervical area, how much function they get back not only depends on what their injury level is, but how able they are to maintain that muscle strength. So passive range of motion, active range of motion are done as soon as possible to make sure that we do those muscle strengths. The other thing, but this is in the future, guys, and what we hope will happen, is that if we can prevent that muscle atrophy, hopefully in the future with stem cell research, that we may hopefully be able to regrow some of that spinal cord and repair that nerve damage. I don't know if you've seen on 60 Minutes and things like that, the mechanical skeletal suits that they've got. But the research is just beginning. And hopefully what we will see in the future is that people that have significant spinal cord damage, if their muscles are not allowed to atrophy, that they will regain functional abilities. So that's one of the things that you want to do. With impaired physical mobility, along with that goes with skin integrity, turning every 2 hours. You're going to use specialty beds if necessary, whether it's one of those airflow beds or the rotarest beds that we use a lot. You may see them use those to help maintain the turning and positioning. And typically the rotarest, any of you ever worked with those? I'll show you a picture of it in just a minute. We used to call them prayer beds. because the nurse was on her knees doing pretty much everything, because to get to the back of the patient, these beds, you don't turn the patient. You turn the bed and open up the port. And you do everything underneath the bed. It's like working on a car. Only you're doing it on the side. You're on your knees taking care of them. And you pray that you don't have the poop port open whenever they go. One of the things that we do is get these people out of bed as soon as that spine is immobilized. Like I said, I was pivoting that patient to send him to PT. We get them out of bed as soon as that halo and vest is on, that spine is stable. Get them up, because thrombophlebitis and DVT are going to be one of your great risks that you're going to see with these patients. Because remember, they have those flaccid muscles. They don't have that push from the muscle on that vein to push that blood back to the heart. So DVT is a great risk. SCDs, TED stockings, love knocks, whatever you're going to do for your DVT protocol, you need to make sure that this patient is on that. Pressure relief devices are also something that you're going to do whenever you get these people up. Now, one of the things that you will see, again, because blood pools with these patients, when you sit them straight up, a lot of time what's going to happen is that they're going to have orthostatic hypotension. Okay, because that blood is going to rush straight down to their legs. And they get dizzy and often have syncopal episodes. What we do to combat that is, this is what, well, no, it's not the Frankenstein table where you zap them with electricity, but it's a tilt table. Basically, what you would do is, this would be flat. You would pull this patient over, strap them in, and then gradually tilt, so that you get a 15-degree tilt, 30-degree tilt, up until they get a 90-degree tilt. So that what you will do is monitor blood pressure, monitor pulse, to make sure that they're not having symptoms of orthostatic hypotension. Until eventually, what may happen is they're able to get into a wheelchair that has the extended back. Okay? The majority of your patients that have cord injury are not going to go to the CVS and buy a wheelchair. They're not going to Sam's to buy a wheelchair. Most of these are specially selected for these patients, depending on what their particular injury and their cord level is. We're talking $7,000 to $10,000 for these wheelchairs, even the non-motorized ones. Okay? Basically, what you would have is this extended back on this wheelchair, so that whenever the patient gets dizzy, you can release this little latch and lower them back just a little bit. And in fact, a lot of times your high quads won't be able to maintain that 90 degrees sitting straight up. They will have a little bit of a lean, and it will help with the dizziness. The other thing that you have to worry about with wheelchairs is the arms do have to come off so that they can transfer. The majority of your patients, if they're paraplegic, are able to do slide transfers with a sliding board and just hop over, but they have to have the arms that come off. These are the functional wheelchairs. Now, when you're talking about the racing wheelchairs or the sports, adaptive sports wheelchairs, you're talking about, those are much more expensive. However, they are very lightweight. They're easier to handle for those patients, and a lot of them have like mountain bike tires, so they're able to do all sorts of terrain. But they are expensive. So please don't lose the parts. for pressure relief, often what you'll see are these geomats. They have a silicone layer with a foam slippery cover. What we teach patients to do at least once an hour is to relieve pressure by pushing up so that their bottom does not get those pressure points on their buttocks and sacral area. The other thing, of course, you'll see is that if patients are able to do wheelchair rolling, that's pretty much preferable to using motorized wheelchairs. Motorized wheelchairs are only prescribed for patients that don't have the ability to do the arms. What you typically will see with these paraplegics, they will have significant upper body strength. And one of the things that we do in rehab is basically get them on the floor and teach them how they get back in their chair. One of the things you have to worry about with patients in wheelchairs is that look at your sidewalks. Okay, here, this area is really very good, except they've got the thing in the wrong place, and it just burns me every time I look at it. But what you're going to see is that if you don't have a sloped sidewalk, then you're going to see a wheelchair that basically is inaccessible to that area. The slope and the sidewalks are basically to allow wheelchair accessibility. But there is a new wheelchair out that will climb stairs. That thing is cool as beans, let me tell you. It's expensive, but look it up on YouTube. But the gloves, very similar to what you see with the weightlifter gloves, are used to basically keep the calluses down on their hands for skin protection. Impaired urinary elimination. Okay. Well, one of the things that you're going to do is, with your patients with cord injury, is that, sometimes you're going to be able to monitor for manifestations of a full bladder. Because if these people have those deep visceral sensations that are intact, they may be able to tell you. However, the majority of times, we just put them on a schedule. Because one of the things that you need to recognize is that normal bladder capacity is about 400 cc's. After 400 cc's, the bladder stretches. Those of us that are nurses or soon to be nurses, probably your bladder will hold 1,000. But that's not what we want for our cord injured patients. We want to catheterize these people. It will say every 4 to 6 hours. It doesn't say every 4 to 6 hours PRN. Okay? The bladder program you're going to put these people on is during the day. Say, for example, I cath at 8 o'clock. I get 400 cc's. I'm going to cath again at 12. I get 500 cc's. I'm going to cath at 3. Okay? Anytime you get over 400 cc's, you should cath an hour earlier. Now, the reason they say 6 is that so that they can be cath prior to sleep and then in the morning. Because remember, one of the things that we don't do is drink fluids all night, or most of us don't. Typically with your spinal cord injured patients, you're not going to cut off fluids at 8 o'clock, but you're going to decrease the amount of intake so that they can sleep during the night without having to be awoken to cath. So what we're going to do is cath them every 4. Greater than 400, you're going to cath them 3. Now, what if I get greater than 400 if I cath in 3? I'm going to cut down on the fluids. Okay, you're not going to cath every 2 hours. Typically, what you're going to see is that these patients only get a Foley in the unit immediately after injury, and that Foley comes out. Just like every other patient, they're at risk for urinary tract infection. The only problem is with your cord injured patients, the most common cause of death in these patients is infection. Either respiratory, being pneumonia, or urinary tract infection. Because these people can get septic in a heartbeat. You're going to teach them how to self-cath. Typically, your patients T1 and below can self-cath. Used to have a patient that could cath herself sitting in her wheelchair. She'd take her catheters to concerts and cath. Used to be what we would do was they would use clean technique. Okay, they'd use the red rubber catheters and then they'd boil them in a pot and then reuse them. So when you went for a spinal cord dinner with someone, you made sure you knew which pot the catheters were boiled in and not the spaghetti. But now what you're seeing, you've seen those commercials on TV, never reuse a catheter again. The sterile ones are much more common and they're gotten to where they're cheap. So you can just use the sterile catheter. Now, if they void, okay, if they trigger void, you're going to monitor for residual. The best way to do that for them out of hospital is to catheterize themselves after a void. What we hope to see is 100 cc's or less, 100 milliliters or less. Now in the hospital we can do a bladder scan, but of course the more accurate way is the catheterization. Dysfunctional GI motility, we're going to put them on a bowel training program. When do they usually poop? Morning or night? You want to know. Because if you're a night pooper, I don't want to get your schedule so that you poop in the morning. You're going to want to make sure that you follow what their routine was. Basically, what you will find is digital stimulation. A lot of these patients will allow them to evacuate their bowel. Sometimes you will have to do a Ducalox suppository or bisacodyl suppository to train that bowel to poop only whenever that stimulation is there. Now, enemas basically are not one of the things that we want to do, because what you're going to find is that the bowel trains itself that that's the only time it's going to go. Okay? The reason we want to put these people on a bowel regimen is so that they will maintain continence of bowel. Typically what you do with that suppository or that digital stimulation is that's whenever it's trained to go, and it doesn't go during the rest of the day. High fluid, high fiber diet. Stool softeners, bisacodyl, colace, whatever, are recommended. And you're going to have them to try to poop sitting up. Laying down on a bedpan is not a way to try to go. Now, Emergency situation. Emergency situation. Emergency situation. 3 times. So guess what you're going to see on that test? Emergency situation. Autonomic dysreflexia will occur after the resolution of spinal shock in your patients above that has an injury above T6. Basically, what you're going to see is bradycardia, hypertension, flushed, warm skin, profuse sweating above the level of the lesion, anxiety. 2 major clues are headache and nasal stuffiness. Okay? Basically, what you get with autonomic dysreflexia is uncontrolled sympathetic response without that parasympathetic to dampen it down. What you see is that some stimulus, a noxious stimulus of some sort. The most common cause is a full bladder. The second most common cause is an impacted bowel. The third cause is restrictive clothing. And then you just sort of figure out whatever else it could be. Bladder fullness, impacted bowel, restrictive or constrictive clothing, and then whoever knows what else. I had someone that developed this because of an ingrown toenail. It took us creation to find that. Basically, what you see with these patients is extreme hypertension. We're talking 220 over 120 or higher. The other thing you will see is pressure areas like decubitus can cause it. Headache, flushed face, decreased heart rate, increased blood pressure, nasal stuffiness. It's triggered by some type of sustained stimuli. It only occurs with people T6 and above. You don't see autonomic dysreflexia below T6. What can happen if it's not treated is these people can have hypertensive stroke and they will hemorrhage into their brain. First thing I'm going to do is put that head of the bed up. Why? What does it do to that blood pressure? It drops it because of why? Blood's going to pool, right? Okay? So what I want to do is get them as straight up as I can. And that will lower my blood pressure until I can figure out what's going on. Okay? Bladder distension. What am I going to do? Cath them. What if it's a bowel impaction? Get it out. But think about this. If I start digitally disimpacting, it's probably going to cause that to go up even more. A lot of times what they will do is do like a pneumocaine or lidocaine on the finger and then do the disimpaction. Okay? Loosen any clothing. If it is a decubitus, treat it. But you may have to treat this autonomic dysreflexia until that wound heals. Now, antihypertensives, maybe. And if the blood pressure comes back down and the signs go away, as soon as that bladder distension is relieved, then you don't need to give them like a PRN. Okay? We would probably give something like a Presolin to lower their blood pressure. But one of the things we want to do is get that head of the bed up to lower that blood pressure to prevent that hemorrhagic stroke. Okay, sexual dysfunction. Remember, a lot of these patients are going to be young adults. A lot of the ones that I've worked with have been 16 to 28 years old. What you will see with males is that intercourse is often possible because what you will see is psychogenic erection. However, usually you do not see ejaculation. Typically, if there is ejaculation, it usually has urine in it. Doesn't cause a problem because usually the urine is sterile unless they've got a UTI. But what you're going to see with males is impaired fertility. The other thing that usually occurs is because they're either paraplegic or quadriplegic, most of the time the testicles sit in the lap. And what happens is it raises the temperature of the testicles, and sperm don't like hot temperatures. That's why you can't get pregnant in a hot tub, no matter what they tell you, by sperm floating in the water. Basically, what you're going to see, though, with a lot of these patients is if they do want to have children, they will do sperm collections and freeze the sperm for a later time. Now, with females, reproductive function is not affected. Ovulation usually resumes after 4 to 6 months. Usually when there's body trauma like that, they quit ovulating for a couple months, but then it resumes. Typically what you will find is that it can be problematic, though. Because think about that expanding fetus in that abdomen. What might that cause for a patient that has a T1 injury? That's autonomic dysreflexia. Okay? Women with spinal cord injury can carry these fetuses to term. They have to worry about that autonomic dysreflexia. However, they will always be delivered by C-section. Okay? They don't have the ability to push. They often, if they don't have that somatic or visceral sensation, they don't feel the labor pains. Okay? Which is why we do epidurals, okay? But what you're going to find is that they usually do C-sections basically because it's easier on the child. One of the things that you will see is that if you as the nurse don't feel comfortable talking about this with your patient, then you need to find someone that is. There are a lot of sexual counselors that work with spinal cord injured patients because, as I said, average age right now is 41. One of the things that you're going to see is that depending on the partner and the client, there may be other ways for sexual gratification. And you need to be comfortable talking about it without doing this number and, oral sex is a possibility, It's not one of those things that you want to be fairly straightforward with these folks. Because they're going to be embarrassed. Their partner is going to be embarrassed. If you're embarrassed too, it's going to be everyone in their little corner. Well, what if, okay? If you're not comfortable, that's fine. There are lots of people out there that that do work with spinal cord injured patients. Well, and if you get into the really raunchy side of the internet, yes, there are. Yes, there are. Basically, sexual dysfunction is something that does need to be talked about, and typically is done not in the acute care hospital, but in rehab. Chronic low self-esteem. Basically, self-care, independent decision-making. You want these patients doing long and short-term goals. I mean, a short-term goal may be, I'm able to sit up today without my blood pressure dropping. And your long-term goal is that I will spend 8 hours out of the bed into the wheelchair in a month. Okay? Clients and families to support groups is very, very important. One of the things that we see is that 50 to 60% of these marriages end in divorce, which is a little higher than the usual rate. Okay? So what we want to do is to make sure that they're sent to counseling. Vocational rehabilitation is very, very important as well for these clients. All right, so ALS. Before I go on, is there any questions about cord injury? Focus on the nursing care. Focus on that autonomic dysreflexia. Okay? Those are the things that you probably will see on NCLEX. Okay. ALS, I think we all saw just the recent fury on the internet with the ice water challenge. That is actually most wonderful because the amount of money for research has greatly increased. What you see with amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease, for those of you that don't know, Lou Gehrig was a baseball player that had this disease. There are lots of others. Stephen Hawking has it. Characterized progressive weakness, muscle wasting, spasticity. Typically what you will see is death due to respiratory failure because the muscle wasting. Typically diagnosis is age 40 to 60, and it's more common in men. In fact, about 10% of your patients with ALS, there's a genetic component. And in the eastern part of the state, there is 1 or 2 families that have a high incidence of patients with ALS. Well, you know, Uncle Joe died at age 45, and he had similar symptoms to what I got right now. So we do see in the eastern part of the state that genetic component with ALS. The majority of it, however, is not genetic. We don't know what causes it. We don't know if it's environmental or viral or what. But typically what you will see is these symptoms. Basically what you will see for clinical manifestations, tongue atrophy. Their tongue actually will get smaller in size, and it will have what we call fasciculations. Is if you have them stick out their tongue, it sort of ripples, okay? You know those little muscle ticks like you get that where it goes, you know, like have you ever seen a horse trying to get a fly off and they flick their muscle? Okay, that's a fasciculation. No, that doesn't mean that if you've got muscle fasciculations where you get this little twitchy face and things like that you've got ALS, because you probably don't. Everyone gets them every once in a while. Most of the time it's due to stress. However, if it's of your tongue, I would get it checked out. Dysarthria, dysphagia are other early symptoms. Typically, these people start slurring their speech, having difficulty with swallowing. With ALS, one of the early definitions or early things that need to be done is discussion of what their wishes are. Living will, healthcare power of attorney are extremely important. Majority of your patients after diagnosis live 2 to 5 years with an average of about 3. From the weak muscles to wheelchair bound to ventilator dependent, if that's the way they want to go.
And this doesn't affect the brain at all.
It does affect their brains sometimes. I mean, there are variants of ALS where they will get like a frontal dementia. However, the majority of times it does not affect the brain. Okay? What happens with ALS is that the nerve cell, the axon dies, and so the dendrite will die, so that it no longer will function. Some of that is in the brain, but typically mentation, they're alert oriented, fully conversant unless they have the variant that's got the frontal dementia.
And I was wondering, the weaker they get and they can't move, but yet their brain's working, how they would get there.
Yeah. Most of the time what you will see is that it's extremely devastating to these people because they're fully aware of everything that's going on. They're just not able to move.
And they can live out 3 years.
How long have you had it?
He has had it for probably 20. He's one of the long survivors. I mean, he's probably brings the average up to the 3 years. I mean, the majority of patients that I've cared for, 12 to 18 months.
He's also got the money though.
Yeah, he also has money and 365, 24/7 care. So, plus he's got the money for the computers and everything for talking. The only FDA approved drug right now is this one. All I can tell you about it is take it on an empty stomach and monitor their liver function. Everything else is treated symptomatically. Okay? The decision of whether they want to go on a ventilator or home ventilator, okay, will depend on what their wishes are. Just as an FYI, I know Ms. Rummel talked about ventilators and alarms and things like that. Those are positive pressure ventilators that we see in the hospital. What you would see at home are not positive pressure ventilators, they're negative pressure ventilators. Basically, a lot of them look like a little turtle shell that goes on the chest, and it's like a little vacuum that sucks the chest out so that the air comes in. They're called cuirass ventilators. They're negative pressure ventilators. So basically what happens is that as that turtle shell moves, it sucks air into the lungs. And that's what we use in home ventilators versus the positive pressure. Okay? Questions? All right. We will do